Okay, ഞാൻ നോക്കട്ടെ ഒരു മിനിറ്റ് പ്രതിഭ, don't go. Okay, can you see the screen now? Hello,
Yes,
screen
sir.
കാണാം. Okay. Okay, Jana, I mean, we wasted nearly 30 minutes, I think, anyway. See, today I would start you on immunology for pediatricians. അപ്പോൾ അത് basically immune, if you want to know immunization, what I trying to tell you is I will go very slow on this chapter, slide by slide, asking you waiting time, because each part of it is very, very important for you to grasp. And unless you know the basis of what we do, many questions which are asked to us, because regarding immunization, the maximum, the final arbitrator is the pediatrician, unlike in many other chapters. If you look now for in the management of any cardiac disease or infections, many other people are also involved. But as far as immunization go, even now the public and the doctors feel that pediatricians are the final people to ask. Therefore, we should be very thorough, not only from the examination point of view. From this we read already yesterday. Mohsen, can you read it fast?
Yes, sir.
Read it loudly.
Vaccination, it is the act of introducing a vaccine into the body to stimulate the immune system to induce protection against infection or disease. Immunization, it is a process by which a person becomes protected against a disease, generally through vaccination.
Please read loudly because it's getting recorded. That's why I'm telling you. Okay. Vaccination is an sorry, is an act of introducing a vaccine into the body to stimulate the immune system to induce protection against infection or disease. Immunization is the process by which a person becomes protected against a disease, generally through vaccination. That's all. Now we will go into types of immunity. We will go fast. These things are known to you, but therefore, Gopika, can you read it? I hope it comes loudly. Okay.
Active immunity is acquired through natural infection or immunization and is long-lasting, as it generally leads to development of memory cells. And when antigens enters the body, strong immune response is mounted. Passive immunity is conferred by maternal antibodies or immunoglobulin preparations given parenterally and is short-lasting depending on the half-life of the immunoglobulins. However, passive immunity provides instant protection required in cases of exposure to certain pathogens, example rabies virus, Clostridium tetani, or hepatitis B virus.
We will go through these slides very fast because almost everything is taken from the Purple Book of Indian Academy of Pediatrics, but not everything. And these things you would be knowing, therefore I am just skipping through, but for completion's sake, I am telling. Okay, read it.
Passive immunity protection is immediate yet transient, lasting weeks to months. Products used include immunoglobulin administered intramuscularly, intravenously, or subcutaneously, specific or hyperimmune immunoglobulin preparations administered IM or IV, antibodies of animal origin, monoclonal antibodies.
Immunoglobulins in pediatric practice is a common question asked both for DCH, and it's sometimes as a short question, sometimes as a long question. Therefore, you must know about it. We will come back into it later, but right now we will. Okay, read the rest.
Passive immunity also can be induced naturally through transplacental transfer of maternal antibodies during gestation. This transfer can provide protection during an infant's first few months of life. Other antibodies, IgA, are transferred to the infant during breastfeeding. Protection for some diseases can persist for as long as 1 year after birth, depending on the quantity of a antibody transferred and the time until level falls below those considered protective.
You would see that I have highlighted that protection of some disease can persist as long as 1 year of birth. What it means also, inhibition also can last up to 1 year of birth. When there are antibodies, naturally inhibition. And this inhibition is more sensitive to viral antigens, therefore viral vaccines. Therefore, you must understand, though we start a vaccination 6, 10, and 14 weeks, there is a level of inhibition, and that's why we postpone the virus and vaccine as much as possible, because protection as well as inhibition can last up to 1 year. But it is not, we will come into a discussion later. Okay, read it fast.
Passive immunity. The major indications for inducing passive immunity are immunodeficiencies in children with B lymphocyte defects who have difficulty making antibodies. Example, hypogammaglobulinemia, secondary immunodeficiencies. Exposure to infectious diseases or to imminent risk of exposure when there is inadequate time for them to develop an active immune response to a vaccine. For example, newborn exposed to maternal hepatitis B and who have infectious diseases that require antibody administration as part of the specific therapy.
These are well known to you, I suppose. Now, this is something I think this is from Nelson's test book, where we give intravenous immunoglobulin therapy. I am not going to go into it. You must know what is available in the market. When do you give IM, IV? And among this, I would say you can go, you should be reading it from Nelson. You can go, when I put this presentation on the, you can go through it during revision also. But I would like to ask you, have you heard about monoclonal antibody, respiratory syncytial virus? Have you heard about it?
Yes, sir.
Yeah, are we giving it in our place?
No.
No, this is, you see, this is one problem which you should understand, and you must be very careful about, because in newborn period, you will find that we are doing advanced neonatology now. You must understand that many children with even 500 grams, 600 grams are coming out alive. They are celebrated. They go out of the neonatology, and they develop a respiratory syncytial virus. They can die suddenly. And this I have seen. The mother would come and say, something is wrong with my child. Maybe nasal block. He's not feeding, but he's feeding, is okay, but he's not crying, he's not that. I mean, very subtle symptoms. When you see he looks almost normal, you send him home, the child dies within 2 or 3 hours. Therefore, this is a we are not giving respiratory syncytial virus. In fact, when I asked a neonatologist, are you giving palmiximab? I was shocked when I came first to India that they told me, what is it? Therefore, there is a danger. Remember this, whenever you get a newborn baby, 2 day, who has, they call the graduates from the newborn care, he comes back to even with a nasal block. Be very, very, very careful, because in India, they are not giving monoclonal antibody. I have asked you several things about it. Is it available? I'm not sure. It was not available about a year ago when I inquired, and many doctors did not know about it. In fact, one of the standard questions asked in most of the international examination is, what are the indications to give a monoclonal antibody for respiratory syncytial virus? And there is a difference between the American guideline and the British guideline. If all this is there, but I have not found it being used in India. I don't know whether it's available. Can you find out if it is available? Okay, Gopika,
Okay, sir.
I'm giving you
Okay, sir.
many things. I told Faisal also many things, but nothing seems to be. I asked about something which is available in India. Dipstick, is it available in India? Urine dipstick.
Yes, sir.
Is available?
Yes, sir.
You inquired? You inquired?
Yes, sir. It is available in Kim's and all.
But in the pharmacy, how can you say Kim's? Pharmacy, in our pharmacy nearby, the hospital, you write a prescription, will you get it? That's very important for the patient. Anyway, now let's go ahead. Now we are we talked about active and passive immunity. There is something else, okay? Now you read innate and adaptive immunity, read it straight down, both of them. Innate, can you read it down?
Innate immunity, the resistance to infection that an individual possesses by virtue of genetic and constitutional makeup, that is by birth. Specificity, it is antigen independent. Time taken to respond is immediate to hours, and memory response is none. Cells involved are dendritic leukocyte, natural killer cells, mast cell, granulocytes or macrophages, basophils, etc. Chemical mediators involved are cytokines, complement, interferon, acute phase reactants. Adaptive immunity, the definition is the resistance that an individual acquires in response to exposure to a foreign substance during their lifetime. Specificity, it is antigen specific. Time taken to respond late to days or weeks. Memory response is present. Cells involved are predominantly lymphocytes, that is killer CD8 plus T cells, helper CD4 plus T cells, B cells, and antigen presenting cells. Chemical mediators are antibodies and cytokines.
Remember, this is the basics you must know. The most important thing I always say, innate immunity is like if you have a what you call a watchman in your house or a watchman in a apartment. He is usually there all the time. He's there immediately. Therefore, this is innate immunity. First is the first level of defense, while this is the second level. This takes hours. Immediately, it comes the hours, within hours, while it takes days. Remember that you may say you are immune, but you take days. You have cell-mediated immunity, and even the production of the antibody takes time, take days. Therefore, the diseases in which you have a short incubation period, sometimes adaptive immunity may be late. That is what it is. This is there. I think you know about it, phagocytes. I don't want to remember adaptive immunity, B lymphocytes, plasma cells, antibodies, the CF, the cell-mediated immunity, antigen processing cells. They we will come into that, and then through cell immunity they come. Therefore, the most important point is the time. That is what is important from the immunization point of view. Okay, read through it now.
Humoral immunity is conferred by B lymphocytes, which is the principal defense mechanism against extracellular microbes and their toxins. These activated B cells differentiate into antibody secreting plasma cells. For effective antibody production, B cells need help from T helper cells. B lymphocytes secrete antibodies that act by neutralization, complement activation, or by promoting opsonophagocytosis, which results in early reduction of pathogen load and clearance of extracellular pathogens. Humoral antibodies prevent colonization, being the first step in pathogenesis by encapsulated organisms such as Haemophilus influenza type B, pneumococci, meningococcal, and organisms such as diphtheria and pertussis. Antibodies are of several different types, that is immunoglobulin G, M, A, D, and E, and they differ in their structure, half-life, and site of action and mechanism of action.
Okay, there's nothing much. I think you know all this. Now I go into the important thing here. This is called the primary immune response and the secondary immune response. And this is the primary response. The most important is the days involved here. Now we will go into, this diagram is taken from Potskin's vaccine, which is the ultimate textbook, which is costing about 10 or 12,000 rupees. I had the privilege. Therefore, the initial antigen exposure, I'll read it out myself, elicit an extra follicular response. What is extra follicular? We will come to that. Results in a rapid rise of low IgG antibody titers, low IgG, as B cells proliferate in the germinal cells and differentiate into plasma cells, IgG antibody increase up to peak level. Here, the problem is it rises, 10 days it rises, then it goes into peak level in 30 days. Remember this, 30 days, and then it comes down. Therefore, you must know that it takes time. Therefore, this is as the results are rapid rise, but low. This is very important, appearance of low IgG antibody titers. Now, next comes what happens is usually reached by 4 weeks after immunization. This is reached after 4 weeks. I'm going slow on this slide because this will come up again and again. The short half-life of these plasma cells results in rapid decline of the antibody titer, which eventually returns to baseline. Therefore, by 30 days, it is high. How long it takes to baseline is not given here. It comes back into the baseline. Now you look at the secondary immune response. Now, in the secondary immune response, note that what rose for 14 days, it starts rising immediately. Immediately. Exposure and reactivate the memory cells and results in rapid, less than 7 days increase. Within 7 days, it is at the top. Actually, it is not, you can't compare this. This is many more times the antibody level is much more. IgG antibody levels, again, a short-lived plasma, maintain a peak antibody level for a few weeks, which they also return back in the same following primary immunization. And long-lived plasma cells that are resurvival niche in the bone marrow continue to produce antigen-specific antibody, which then decline. In a secondary immune response, there will be some plasma cells in the bone marrow. We will show it in the few slides that come afterwards, and they maintain, then decline kinetics. Generic pattern may not apply to live vaccine because this is what happens when you give a killed vaccine. This is the primary antigen. The secondary response is obtained during booster antigen. For booster, it goes up. Remember, within 7 days, it is on the top. The other 30 days, the peak is very high. The peak is not that narrow, but still it comes down very rapidly, and then it comes. Therefore, this is a time interval is very important. Here, 30 days, it comes down. Here, 30 days, even after 6 months, it remains. So this is very important in the in what with this diagram is should be impacted in your antibody level. But what you see here, the peak and this peak is not equivalent because this will go out of the graph, many times out of the graph. This you must be knowing. You can anyway, because this is so fundamental, I want you to read it. Can anybody read it? So must be loud. Mohsin, can you read loudly? I think Mohsin is not there.
Right. Primary versus secondary immune responses. When an
Uh,
antigen is introduced for the first time, the immune response starts after a lag of 10 days or so. This is called primary response. In primary immune response, the antigen exposure elicits an extra follicular response that results in the rapid appearance of low IgG antibody titers. As B cells proliferate in uh,
Germinal centers.
then and differentiate into plasma cells, IgG antibody titers increases up to a peak value, usually reached 4 weeks after immunization. The short lifespan of the plasma cells results in rapid decline of antibody titers, which eventually return to baseline levels. Secondary immune responses start on subsequent exposure or booster to the same antigen, and there is no lag phase. Response after immunization starts in less than 7 days, persists for a long time, mainly IgG type with high antibody titers. In secondary immune responses, booster exposure to antigen reactivates the immune memory or memory B cells and results in a rapid, that is less than 7 days, increase of IgG antibody titer by a rapid proliferation of memory B cells and their evolution into abundant antibody secreting plasma cells.
There are a few points which have to be understood. The primary immune response is not so good because last starts at 10 days, peaks at 30 days. So even the second, the extra follicular, etc., and the first one is rapid appearance of low IgG antibody titers. Now, it takes in the secondary immune response, they say there's no lag period, but it starts, really starts peaking only less than 7 days. It takes 7 days is a long time. Many diseases have an incubation period, 5 days and all that. Okay, we know that. Many are, therefore, it may be too late for some of our diseases also. And the secondary immune response is usually it gives higher titer of IgG antibody titers. What I want to inform you is that the secondary immune response by itself is also a little late in some diseases. Okay, go ahead.
Primary versus secondary immune responses. Short-lived plasma cells maintain peak antibody levels during a few weeks, after which serum antibody titers decline initially with the same rapid kinetics as following the primary immunization. Long-lived plasma cells that have reached survival niches in the bone marrow continue to produce antigen-specific antibodies, which then decline with slower kinetics. This generic pattern may not apply to live vaccines, triggering long-term IgG antibodies for extended periods.
Because the live vaccine keep on multiplying in the body, it produces the primary and the secondary immune response with a single dose. That's what we will come to. Now, the next diagram is very, very important. It is there in the IAP guide, IAP book also, but better I have taken it from some other book, Podkins test book, and I will explain it very carefully. You should know it very, very well. This will keep on coming again and again for you. And this is the spleen of the lymph node. This is the blood. This is the bone marrow. And this is the germinal center in the spleen of the bone marrow. Now, what happens? I have taken it from Podkins' vaccine book. Now, we will see what happens here. Now, first thing that happens is here. In response to protein antigen reaching the lymph node or spleen, this is protein antigen of the microbe, I mean, capable of or the vaccine which you are giving, surface of undergo brisk activation. Here, which enters the one is B cells brisk activation, differentiate into plasma cells, and produce low affinity antibodies. Remember this is outside the germinal center of immunoglobulin IgG that appear at low levels in the serum within a few days after immunization. Very important point. It is outside. Remember this. We'll go slow on this slide. Antigen, which is your vaccine. How the vaccine proliferate the B cells, plasma cells, low affinity Ig in low titers. They come in a few days. They come into the blood cells. Now come antigen. Now comes the T cell. Antigen specific T helper cells that have activation by antigen bearing dendritic cells. They are activated by dendritic cells. We'll show that later. Initiating the germinal center reaction. This gets involved. In germinal center, therefore, what happens without the T helper cells, the B cells here, which produce antibodies, cannot enter the germinal center. With the help of the T helper cells, which were activated by the antibody produced dendritic cells, B cells receive additional signals from follicular T cells. Therefore, it enters B cells, follicular T cells are there, undergo massive clonal proliferation, switch from IgM towards IgG, IgA, or IgA, undergo affinity maturation. All points are very important. In the germinal center, it takes place a massive reaction. That is, they are in the G cell, B cell, because of the helps of T follicular cells. Here, T helper cells outside make them enter the body, and then you have this. They enter and they get B cells rapidly differentiate, produce low. The next is they enter here and they get the help, trigger some antigen specific to migrate towards the follicular dendritic cells, initiating germinal center reaction. The T follicular helper cells also help and undergo massive specific clonal proliferation, switch from IgM to IgG. This is what happens in the germinal center and differentiate into plasma cells secreting large amount of antigen specific antibodies. Difference is this is low titers, mainly IgG. Here you have massive amounts antigen specific antibodies. This is specific at the end of the GC reaction, a few plasma cells, end of the germinal center reaction, a few plasma cells enter the bone marrow. A few plasma cells exit the nodes and spleen and migrate to survival, mostly locate in the bone marrow, where they survive through signals provided by supporting stromal cells. This is the essence of the of the reaction, and you must know this. And this germinal center reaction takes very good, but takes time. And this provides the long-term immunity in that. We will come to that later. Therefore, this, for just for seeing this is another which gives you an idea. I don't want to spend time. I've already explained this. These slide will be in the slides I give you. Now, very important here is when the germinal center produces the plasma cells, we are very clear, it does something else also. It produces the memory cells. That's what here it has already produced antibodies. We have already a response. It has produced a. Now, what happens next is memory B cells are generated response T cell. Here, not only high amount of IgG and IgM specific are produced, but memory cells are produced. Memory B cells are generated in response to two dependent antigens during the germinal center in parallel to plasma cells. Therefore, memory B cells, remember this, along with plasma cells, are produced only in the germinal center. They persist there as resting cells until re-exposed to the specific antigen. On secondary exposure, memory rapidly proliferate and differentiate into plasma cells. Now, what they do is they actually migrate to from the germinal center, they migrate to the periphery. Now, normally, when you have an antigen, it produces only low level of primary response. If it has to produce a secondary response, it has to go inside the germinal center, T cell. It takes about 4 to 6 weeks, sometimes months. But once you have memory cells outside, I'll say once you have been what you call primed, the memory cells are here, they rapidly produce secondary immune response from here. This is a very important point. You have primed, the memory B cells are ready to produce a secondary immune response. In the primary, therefore, this is the time interval will be proliferated. The antigen does not have to produce B cells which have to enter the germinal sensor. Therefore, they produce large amount of high affinity antibodies. Therefore, this is high affinity antibodies within a few days after boosting. But remember, there are also a few days. Therefore, this is what it is all about. Now, I am supposed to teach you only primary immunology, but I will slip into some practical things which you should know by this time. That is in, say, when you have two or more live parental intranasal vaccine are not administered on the same day, when two or more live parental parental intranasal vaccine are not administered on same day, they should be given 28 days apart. This rule does not apply to live oral vaccine. If given within 4 weeks apart, the vaccine second should be repeated at least 4 weeks after the early dose. Which are the live vaccine which we are likely to give together? Can you tell me? Mohsen, can you tell me the live vaccine which we are giving in our hospital? Are you there? Gobi
Yes,
Undok,
sir.
you're not answering. What's the live vaccine which we give to our children?
My live vaccine?
Mohsen, be louder. I can't hear you.
Background sound ഇതാണ് sir. പറയാം sir.
Gopika, can you
Hello?
answer?
Sir, OPV.
Yeah, OPV.
Rabies, sir. Rabies.
Rabies is a killed vaccine.
MMR.
MMR, very good, MMR. MMR is the one vaccine which we are giving, live viral vaccine. Anything else? I'm asking you a straight question. Sometimes we don't give it. It's not in,
Varicella.
huh?
Varicella.
See, as far as I
Varicella.
know, there is something called live influenza vaccine, live hepatitis A vaccine, etc., which we are not giving. The other vaccine which we are giving is varicella vaccine. Remember this, okay? The varicella vaccine, which sometimes we do give. Therefore, if you give a measles vaccine today, MMR vaccine, then you should not give chicken. Either you give on the same day or you give after 4 weeks. Why? Because you see the antibodies produced in the, it will be at the peak up to 4 weeks here. And when you give the second vaccine, it is not able to multiply because there is interference from those antibodies. The minimum interval the between two dose inactivated vaccine is usually, there's a difference here. 2 or more live intravaccine, minimum 2 doses of inactivated vaccine. That is, if you give DPT today, when do you repeat the DPT for the second about is again 4 weeks, exception being rabies. And vaccine doses administered up to 4 days before the minimum interval or age can be counted as valid. Very, very important point. You may ask, why should there be a minimum period? Let them come after 4 days. Any number of days after that is okay. But you cannot give 4 days before. If you give on the 1st of May the DPT, you can give the second dose, say 28th. Now, suppose she comes on 24th or 25th, you can give, but 20th you cannot give. You may ask for what is this important? It is important. When you today, when people are traveling, especially abroad and all that, they come and ask you, doctor, we are going abroad, we are going to Gulf, taking a child to be with his father during holidays, and we are leaving on this day. Can we take a vaccine? Now, kill the vaccine up to 4 days before 4 weeks you can give, but if you give before that, it will not be counted, because the same vaccine, we are talking between 2 doses of the inactivated vaccine. That's one thing. But what's the next? Read it, Gopika.
If the vaccine is administered more than 5 days before the minimum period, it is counted as an invalid dose and has to be repeated. This rule does not apply to live parenteral vaccines. Any number of antigens can be given on the same day. 2 or more inactivated and live vaccines can be administered at any interval between them. 2 or more live parenteral vaccines should be administered on the same day or 4 weeks apart.
But this is very, very important for you to know. Previously, it was considered that 2 live vaccines cannot be administered at the same time, because the multiplication of one virus will lead on to the inhibition of the other virus. For example, we have super added bacterial infection. You have a virus, pneumonia, you can get a super added pneumococcal onto that. But generally, there is nothing called a super added viral infection, because virus generally produces interferon and cytokines and interfere with one another. Therefore, they used to say that you cannot give 2 viral vaccines together, but later they proved you can give it at the same time, MMR, you can give it today. But suppose you give measles today and I want to give rubella, then you will have to wait for 4 weeks. Therefore, but at the same time, you can give combined 2 killed vaccines, everything. We will come into that later. Now you read it fast now. Now we must know what happens in the step of immunization and the basic things that happen here. Okay, read it.
First step after immunization, due to focal lymph node activation, multiple killed vaccines may be administered at different sites and at different time intervals with little immunological interference. Immunological interference may occur with multiple live vaccines unless they are given on the same day or at least 4 weeks apart or by different.
I am repeating all this. This should be ingrained in you. Please remember this. Okay. Can you read it? Can you see this?
No, sir. Previous slide only.
You're not seeing how a
Yes, sir.
rotavirus.
Yes, sir. Now I can see.
Okay.
However, rotavirus vaccine and oral polio vaccine can be given simultaneously or at any interval before or after any inactivated or live vaccine.
That's something very interesting. We we are talking a rotavirus vaccine and oral polio vaccine. Can it be given to simultaneously, because both are viruses? Now we have to give it because in our vaccination, because we are giving OPV. But there is some in our country, as far as India is concerned, we can give it. It can be given simultaneously or at any interval. But if you look at Espajan, they say don't give OPV and rotavirus at the same time. They don't like it. But American Academy of Guidelines are not interested because they don't give oral polio. but the both of them have to multiply. Only parental live viral vaccine have to be 4 weeks apart. Oral live vaccine can be given at the same time or at any interval, though there is some problem regarding that. So this should be very well known. You read it now. Can you read?
Sir, the slide is not seen, sir. Yes, sir, I can.
Yes.
Recommendations for spacing of vaccines. 2 or more inactivated vaccines may be administered or together or at any interval between doses. Inactivated and live vaccine may be administered or at any interval between doses. 2 or more live parental vaccines may be administered on same day or at an interval of at least 28 days. PCV13 and Menectra should not be administered at the same visit. Separate these vaccines by at least 4 weeks and administer PCV first.
Well, there is something very technical about it, which we will discuss when we discuss Menactra and everything. Menactra is something which we are not giving. Okay. Therefore, I will not go into it. Very important. But what is very important is remember 2 or more live parental vaccine are the only thing which may be administered on the same day or an interval of 28 days. Therefore, this is very important for you. You may think, what is it important? Because today the patient will come and say, doctor, we have everything. We are given all the vaccine, but today PCV is not available. It will come within 2 or 3 days. Shall I come and take everything together, or shall I come and take, can I postpone? Yes, you can, because PCV is a dead vaccine. It doesn't matter. And you can combine inactive and live vaccine. MMR is not available. You can ask them to take the rest of it and take the MMR. But if they are going abroad, they want to take live vaccine, MMR and varicella, they should take at the same time. Remember this. They are going abroad. Many people go to the Gulf during holidays. They take the children with them. We want to take the vaccine early. Up to 4 days you can take. Before that, you cannot take a kill vaccine. Then it will not be counted. And live vaccine is not a question of 4 days or one day. You can give only after 28 days. Remember this. These are fundamental. Even now, many pediatricians make a mistake in this. Okay. Okay, read it now. I think it's taking time now to come.
Determinants of intensity and duration of immune responses. Primary immune response after vaccination depend on various factors such as vaccine type, nature of antigen, vaccination schedule, genetic and environmental factors, and age at immunization.
The second portion has come.
No, sir.
Taking time. I don't know why. I think it will come now. Okay.
Types of vaccine, broadly speaking, live vaccines are superior. Exception is BCG and OPV to protein antigens, which in turn are superior to polysaccharide vaccines. Live versus inactivated. Higher intensity of innate responses, higher antigen content following replication, and more prolonged antigen persistence generally result into higher antibodies responses to live than inactivated vaccines. Protein versus polysaccharide, recruitment of T cell help and induction of germinal centers result into higher antibody responses to protein or glycoconjugate than to polysaccharide vaccines.
Simple is that the live vaccine produces a primary and the secondary immune response, and generally initially was considered did not require booster doses. But we will come into that later. Because it keeps on multiplying in the body, it produces germinal center, everything will come into that. Protein, polysaccharide antigen do not enter the germinal centers. If they don't enter the germinal centers, they only produce low level of antibodies. They cannot produce memory cells. They cannot produce many things. That is a problem. To enter the germinal cell, we will come into that. Therefore, this is the primary response between these two vaccines. Has the slide moved for you?
Not yet, sir.
I don't know why it's taking time. Anyway. Not yet?
No, sir.
I will start reading the slide. When it comes, you start reading. It's still not come there?
No, sir.
I don't know what's going on.
Yes, sir. Now it came.
Okay, go ahead.
Determinants of intensity and duration of immune responses. Adjuvants. Adjuvants improve the immune response to inactivated vaccines by either modulation of antigen delivery and persistence, that's depot or slow release formulations, or enhancement of the pH responses, immunomodulators, which may support to limit the antibody responses. Thus, less amount of active ingredient per dose is required for an immune response similar to vaccines without adjuvants. However, adjuvants may cause some side effects. Antigen nature, polysaccharide antigens failure to induce the germinal centers limits immunogenicity. Protein antigens, inclusion of epitopes readily recognized by B cells, that's B cell repertoire. Inclusion of epitopes readily recognized by the follicular helper T cells, elicitation of efficient follicular T cell help, and the capacity of antigen to associate or persist in association to the FDCs result into higher antibody responses. Antigen dose. As a rule, higher antigen doses increase the availability of antigen for B or T cell binding and inactivation, as well as for association with the FDC. However, there is limiting dose of each antigen.
Well, we'll have to wait for the next slide, I think. It's about secondary immune response. I will start reading. When the slide comes to you, you start reading. Continue it.
Okay, sir.
Secondary immune response, live versus inactivated. Live vaccine generally induce more sustained antibody response. Because I am repeating, this is again and repeated to drill into you, presumably through prolonged antigenic persistence with the host. Secondary response with inactivated vaccines are highly pronounced and amnestic. Now, however, secondary response are usually blunted with live viral vaccine as pre-existing antibody neutralizes the vaccine virus. Actually, the primary dose you give itself multiplies. It multiplies, produces germinal center, memory cells, everything. And the secondary response is blunted. But in inactivated vaccine, there will be a secondary response because there is the previous bacteria and antigens are not there. Polysaccharide failure to generate.
Polysaccharide antigens failure to generate the germinal centers limits the induction of memory responses and of high affinity long-lived plasma cells. Secondary immune response does not occur with polysaccharide antigens. Interval between the primary doses. A minimal interval of 4 weeks between the primary doses allows development of successive waves of antigen-specific primary responses without interference. Interval before boosting. A minimal interval of 4 months between the priming and boosting allows affinity maturation of memory B cells and thus higher secondary responses.
These are well known. Minimum interval 4 months. Why? Why they can ask you between priming and boosting allows affinity of the maturation of the B cells and thus higher secondary immune response. That is why if you want a booster dose from the primary dose, normally it is given 0, 1, and 6 months minimum. But sometimes you can give within 4 months. Sometimes, when children come to you without a total lack of immunization, you want to give the booster early, you can give it 4 months, minimum interval 4 months, because you should have given time for maturity of the B cells. Interval between 4 weeks between the primary doses, because we want the previous antigen specific antibodies to come down. minimum in 4 weeks between primary allow develop successive waves. After the primary antigen, then only you give 4 weeks. These things are well known now. Now, these are finally age at immunization, early life immaturity, and age-associated immunosense limit the induction persistence of long-lived plasma cells. There's a problem in scheduling the immunization, you know very well. We want to give it as late as possible because the antibodies will not interfere with your immunization. At the same time, you have to give it early because if you delay it, the child may catch other diseases also, because he may catch whooping cough, he may catch tetanus, etc. Therefore, we can't delay it too much. Therefore, age at immunization is a trade-off between when you want to give. Okay, now the basis of how immunization works. There is something called types of vaccine, which is live vaccine and inactivated vaccine. You know most of it. Just I want to point out here one thing. Have you seen the screen? Hello?
Yes, sir. Can be.
Yes, sir.
Yes, sir.
What are you saying? Is it
Types of vaccines.
Types of vaccines.
you are seeing the list? Is it?
Yes, sir.
Vaccines may be
Okay.
classified as
Now you
follows.
must know certain things here. The live attenuated vaccines, you know, polio, measles, MMR, varicella, rotavirus. I think the influenza and the hepatitis A available here are killed vaccines. Now we know the inactivated vaccine. I don't want to go into this. Remember that human papilloma virus is virus-like particles. It is coming under inactivated vaccine, virus-like particles. And remember, the COVID vaccines are also DNA and RNA viruses are in the inactivated virus. Why I'm emphasizing to you this point is during the COVID time, there was a big debate. You would find even people coming on the television and telling booster doses are not required because this is viral vaccine, live viral vaccine. Yes, it is virus, but it's only contained DNA vaccine and RNA vaccine, and technically they are inactivated vaccines. If they are inactivated vaccine, they definitely require booster. First, the government did not talk about booster because they didn't have the vaccines. There was generally, definitely, if you are taking DNA, I think we will come into that later. We will come DNA and RNA viruses. From the immunological point of view, I think boosters are required. Now, has it changed your slide? Influenza vaccine live in and zoster vaccine live is
No,
also
sir.
available. See, another vaccine which is now being available in the market, which is a live vaccine, is the zoster live vaccine. And zoster live vaccine is now advised for senior citizens. Above 50 years, it is advised. Costly vaccine costs some 9,000 to 10,000 rupees. But as a pediatrician, you should know what are the live vaccines available in the market: measles, MMR, varicella, and zoster. COVID vaccine, Cori, DNA and RNA, but I don't think that is available. Now, what happens in a tissue when you have given the immunization? Are you seeing the picture?
Sir.
Yes, sir.
Yes.
Okay, now I don't know what happened. Now it is coming. Anyway, now you should know that this is what happens is, you know, but I am trying to emphasize to you what happens when you give a vaccine. You are giving a vaccine in the this is one, you give the intramuscular injection. What happens is the pathogen associated pattern contain the attract the monocytes, neutrophils, and patrol through the body. But you're giving in the muscles, and they attract the monocytes and neutrophils and dendritic cells. Therefore, the dendritic cells are more present in the muscle. They are more present in the intradermal region, but they are not present much in the subcutaneous tissue. Therefore, subcutaneous injections are not good. Therefore, you attract them. Then what happens is the elicitation of the danger signals, the vaccine antigens activates monocytes and dendritic cells. That is number two. Elicitation substance, danger cells, they are activated. The activation changes the surface receptors and induce their migration into the lymphatic vessels, draining lymph nodes where they are activated by where the activation of T and B lymphocytes take place. Therefore, they come here, the antigen, and they start migrating to the local lymph node. This is the in the response to a killed vaccine, and in the lymph node, the B cells get activated. T and B cells get activated. Remember this. It's a very simple diagram. Now, can you see this next slide now?
Yes, sir.
Okay, read it now fast.
First step after immunization. Following vaccine injection, the vaccine antigens attract local and systemic disease, monocytes and neutrophils. Innate immune responses activate these cells by changing their surface receptors, which migrate along lymphatic vessels to the draining lymph nodes, where the activation of T and B lymphocytes take place. The type of response elicited will depend upon the type of vaccine, its antigenic type and content, and immune status of individual. Vaccines that stimulate innate immunity effectively are based better immunogens. This can be achieved by live vaccines, adjuvants, TLR agonists, live vectors, and DNA vaccines.
Okay, Mohsen, your voice is very slow. Therefore, I will ask, uh, who else is there? Only Gopika and Ashwati is also there? Okay. Gopika, can you read it?
Is that,
Read this now.
should I read again, sir?
No, no, read the next slide. It has changed.
In case of killed vaccine, there is only local and unilateral lymph node activation. Consequently, the immunogenicity of killed vaccine is lower than the live vaccines. Killed vaccines require adjuvants, which improve the immune response by producing local inflammation and recruiting higher number of disease or monocytes to the injection site. Secondly, the site of administration of killed vaccines is of importance. The intramuscular route, which is well vascularized and has a large number of petrolin disease, is preferred over the subcutaneous route. Intradermal route recruits the abundant disease in the skin and offers the advantage of antigen sparing and early and effective protection, but the geometric mean titers are lower than that achieved with IM and may wane faster.
A very important statement here, which you must understand. This is very, very, what you call sensitive in our place. Where are we giving intradermal injections of vaccines? Which vaccines are we giving intradermal? Gopika, you are there in the department for nearly 2 years now. Which vaccines in our hospital is being given intradermal? In the health center, in the government hospitals, are given intradermal. Basically, because to save the dose. Mohsen, can you answer? Mohsen, you are there? You are not
Sir,
there, or you don't?
BCG and rabies vaccine. Rabies.
Very good. At the end of the day, I think you Googled and searched. Anyway, it is this PCV. We are not PCV. We are giving IPV. IPV is given intradermally also in the government sector, because they say up to one dose is you can say 5 doses. One IM dose you can give 5 intradermal dose. And similarly in rabies also, intradermal doses are now being varied because you can save on the vaccines. But what does it say? Basic immunology, yes, offers advantage of anticipatory early effective, but the geometrical mean titers are lower achieved than with IM and may wane faster. This is given in the IAP immunization book. Remember this. Therefore, when you have patients, you're going to give rabies vaccine, give the IM dose. Why? Because you can't give it to 5 people at the same time in private practice. IPV also, you cannot give, you may not have patients to give IPV for 5 people. But remember that whenever they say that intradermal rabies vaccine is as good as IM, at the same time they say the child is immunosuppressed, don't give intradermal. What does it mean? Therefore, there seems to be a superiority for the IM dose. But whatever it is, we don't want to go against the but read in between lines and understand that the protection given, definitely the dendritic cells are very high in the intradermal area. 1/5 the dose may be enough. But remember that in the IAP book itself, it is given that the geometrical mean times are lower than achieved than IM and may wane faster. Therefore, if you are giving IM IPV, nobody can blame you. Okay. Live vaccine, it is of less significance how you give it. Has it changed the slide? Hello?
No, sir.
It's a problem. I will start reading. When it comes, you can read. This is from Podkin's test book. This is the final book. The site and route of administration is thus more important. The high number of dendritic cells in the dermis allows a marked reduction, tenfold, of the antigen dose of the intradermal immunization. I wrote this because it is given in the most authoritative test book on vaccine, which is Plotkin, tenfold. This advantage of the dermal dendritic
This
cell
advantage of the dermal DC concentration is applied to the prevention of rabies in many countries and could prove useful against additional targets as novel microneedle and needle-free devices become available for intradermal administration. Petrolin DCs are also numerous in well-vascularized muscles, which is the preferred route of injection for non-live vaccines. They are fewer in adipose tissue, such that subcutaneous injections may be less effective than intramuscular injections under conditions of limited immunogenicity, as demonstrated for adult immunization against hepatitis B.
Now, there's some other vaccine which we give intradermally, which is what is the vaccine? Routinely, we give intradermally. In our place, in our immunization clinic, we are giving intradermally every day, which is the one.
Rabies vaccine.
Rabies vaccine is not given every day. Which other vaccine in the immunization schedule is given intradermally, should not be given intramuscularly. Rabies can be, polio can be given intradermally. BCG. Have you gone and seen a BCG being given? Have you gone and seen? What's the problem with intradermal injection? Can you tell me?
Painful, sir.
Huh? It's painful. Did you ask the newborn baby? Is it painful?
Technique.
Yeah. Most
Technique.
please let me tell you, both of you, if you are a pediatric resident, please go beg with the nurse and the nurse. Give at least 10 doses of intradermal BCG. Intradermal. Why I'm asking you is, when you start your practice tomorrow, if you are giving immunization, please be very careful with the nurse who gives BCG, because intradermal is not that easy to give. How to give it will come later. And you have to be trained. Even doctors don't know. If you give subcutaneously, two things can happen. One, it may not be effective. The BCG may not be effective. And number two, it might produce more of lymphadenopathy. That is debatable. If I remember here that intradermal injection is not that easy, and the Podkin's test book itself says that the dose reduction of tenfold may be required, and this advantage can be used in the prevention of rabies. But when it comes to your private practice, probably it is not practical. Anyway, you have to break a vial. You can't give it to 10 people at the same time or 5 people at the same time like you give in governments. Therefore, you can give it IM also. I mean, IM dose. And I read in between lines when they say that you can give it for normal children, but not for immunosuppressed children. What does it mean? Therefore, that means that the intramuscular route is more. But when you go for a debate, they will tell you studies have not been done of intradermal in immunosuppressed patient. That is the reason we don't advise. But whatever it is, if you are in private practice, you're fully justified in giving the IM dose, full dose, because you're not going to save on the vaccine. BCG, please go to the yard, beg the nurse there, sit there and try to give intradermal, or at least try to give intradermal test dose of penicillin if you are giving in the ward. You may not need to know how to do a bone marrow. This is not necessary as a general pediatrician, but you must know how to give IV fluids, how to put the IV cannula, how to give an intradermal dose, etc. Okay, now read it fast. Has it changed for you? Has the slide changed? No, huh?
Yes, sir.
Yeah, can you read it loudly, Mohsen? Is there any way you can?
Background is. Yeah.
Or is
I'm at home actually.
yeah, anybody else? Is only you
Yes.
two are there?
Ashwari
Gopika,
is a classmate. Sir, now
Ravi
I
has-
can
okay.
first step after immunization. Is it okay, sir? Sound.
Yeah, little low, but okay, read it. Okay.
Due to focal lymph node activation, multiple killed vaccine may be administered at different sites and at different time intervals with little immunological interference. Immunological interference may occur with multiple live vaccines unless they are given on same day or at least 4 weeks apart or by different routes. However, rotavirus vaccine and oral polio vaccines can be given simultaneously or at any interval before or after any inactivated or live vaccine.
Now I put up the slide again for this one. Why I said about it is, see, the first sentence, due to focal lymph node activation. Therefore, that means when you give a killed vaccine, it goes only to the focal lymph node, while while live vaccine will go and go to multiple lymph nodes. Therefore, you can give a kill vaccine one. You want to give another kill vaccine, you can give on the other hand because it doesn't affect at all. Okay, can you read it? Has it changed for you?
Yes, sir. First
Okay.
step after immunization.
Yeah. Live vaccines.
Live vaccines are capable of activating innate immunity in a better way, which is helpful for the subsequent induction of adaptive immune effectors. During the journey, the attenuated organism undergo dissemination and replication and activate a large number of DCs. The activated DCs migrate towards the corresponding draining lymph nodes and launch multiple foci of T and B cell activation. Evisa.
Live
Live,
antivirus.
live,
Yeah, live
LAVs stimulate an excellent immune response as they mimic a natural infection. Large number of DCs take up vaccines antigen in multiple tissues and provide continual antigenic stimulation, giving sufficient time for memory cell production.
what it does is it does produce a primary and a secondary immune response because it's keeping on multiplying. It is not only giving stimulating the local lymph node, but it also goes and stimulates all the drain lymph nodes all over the body, T and B cell. That is why you can give a kill vaccine in one hand and the other kill vaccine at the same time. I mean, at any time on the other hand. But live vaccine, it doesn't work because all the lymph nodes are affected. And remember this, they mimic a natural infection. That is a very important point because if you get a measles, usually you are unlikely to get a measles in your lifetime, though there are exceptions. If you get a chickenpox, it's very unlikely, but secondary infections do occur, but they are less severe because body keeps on multiplying in the body and produces a primary and a secondary immune response with memory cells, with cells in the bone marrow which act as reserve cells. Now, can you read? Has it changed?
Yes, sir. Immune response to live vaccines. Live vaccine induce an immune response similar to that seen with protein vaccines. However, the take of live vaccine is not 100% with the first dose. Primary failure, hence more than one dose is recommended with most live vaccines. Once a vaccine has been taken up, immunity is robust and lifelong, or at least for several decades. This is because of continuous replication of organism that is a constant source of antigen. The second dose of that vaccine is therefore mostly for primary vaccine failures, no uptake of vaccine, and not for secondary vaccine failures, that is decline in abs over time. However, mumps does not follow these general principles. Waning antibody levels has been demonstrated, therefore the need for subsequent doses.
Now, booster doses, subsequent doses as are required. Now, there are many things will come up as we discuss as along. This is a very important topic, very important topic. Live vaccine, do they require boosters? When we were students, we were told live vaccine, no booster. But in measles, which was the only thing available, was given at 9 months, but the second dose was given at 15 months. Because at 9 months, the live vaccine, which you may not be effective, but then why you are giving at 9 months? Because a certain percentage of measles occurred in children below 1 year, and those children had the maximum morbidity and complications. Therefore, naturally, we had to give at 9 months. It may not be effective. We gave another at 1 year. Now, why are we giving? The first question that we asked is why were we giving multiple doses of oral polio? Yeah, it is because it is oral, and each dose either hit or none. You give oral polio, if it is effective, that's enough. But you don't know. Therefore, you give multiple doses, hoping that one of it will be effective. Is it true with the rotavirus? I'm not too sure. But whatever it is, but then what has happened is they are telling that primary failure is the reason. No, many children who had been given measles, is this has happened in measles also, started developing measles at the age of 11 years, 12 years, 14 years, etc. The measles epidemic changed from childhood to adult. Therefore, that is why they started giving a booster dose also. Therefore, finally, you don't wait on the theory alone. In practice, you see whether it works. But in mumps also, they found that it does. Later on, people started getting mumps, and mumps in adults is more dangerous than in children because it can cause parotitis, pancreatitis, etc. Therefore, they started giving booster doses. Therefore, nowadays, for practically all live vaccines, there is a booster dose which is often given because it is not only due to primary failure, the vaccine protection also seems to wane. That we will come up later. But at the same time, for example, a hepatitis, you are given the dose, boosters are usually not required. Hepatitis B, remember this, hepatitis B, in Western countries, 2, 4, and 6 months, no booster at 1.5 years, no booster later on. That we will discuss it later, why in the kill vaccine they are not giving. Now we are talking of polysaccharide bacterial antigen. Okay. Can you read? Has it come up?
Yes, sir. Yes, sir.
Yeah.
Immune response to polysaccharide antigen bacterial, that is Streptococcus pneumonia, Neisseria meningitis, Haemophilus influenza, and Salmonella typhi. PS antigens are T cell independent antigens. On being released from the injection site, they reach the marginal zone of the spleen or nodes and binds to the specific immunoglobulin surface receptor of B cells. In the absence of help from specific T cells, B cells activate, proliferate, and differentiate into plasma cells without undergoing affinity maturation in germinal centers. The antibody response sets in 2 to 4 weeks following immunization and is predominantly IgM with low titers of low affinity IgG. The half-life of the plasma cell is short and antibody titers decline rapidly. Additionally, the PS antigens are unable to evoke an immunoresponse in those aged less than 2 years due to immaturity of the marginal zones. As PS antigen do not induce germ cells, bona fide memory B cells are not elicited. Consequently, subsequent re-exposure to the same PS results in a repeat primary response that follows the same kinetic in previously vaccinated as in naive individuals.
Okay, when you have polysaccharide antigens which are not conjugated with a protein, it indicates, I have already pointed out, it only elicits the germinal centers. No, sorry, it only extrafollicular area. Okay, therefore it doesn't go into the germinal centers. Therefore, memory cells are not there, and there is no high level of antibody. It only works on the what you call the marginal zone of the lymph node, and I don't know why it's not coming here. 1 minute. It comes only on the marginal zone of the spleen and lymph nodes. It doesn't enter the germ cells. But this is very important, and unable to evoke an immune response below 2 years because of multiple reasons. One of the reasons is immaturity of the marginal zones. Therefore, they don't have memory B cells. They cannot be there's one more point which will come up later. Subsequent re-exposure, it again produces a primary response. But what is the polysaccharide bacterial antigen immunization which we give? Mosin, which we may be advised, which may be forced to give in India. Which polysaccharide vaccine are we giving? Gopika, are you there?
Please, pneumonia.
Pneumococcal 23 vaccine. You understand? Polysaccharide pneumococcal, I think it's called 23 vaccine. Which children get it?
Immunocompromised.
Which of our
clinic,
patients may need it?
Person undergoing any transplantations before.
Okay. Doctor, you're going to appear in North India with North Indian examiners, with you going to appear in Tamil Nadu, where the diseases may be common. You may go and appear in Calicut, where a particular hematological
Malaria.
disorder. Which one?
Uh,
I think you people have not spent any time reading immunology. When there is a very beautiful book called the
Sickle cell disease, those who underwent splenectomy.
yeah, which diseases have an autosplenectomy? Sickle cell disease. Remember this, all sickle cell patients after primary immunization at the age of 2 years, they are given polysaccharide antigen bacterially. Now, this may become not reason because it contains 23 antigens. But now we have having PCB 15, that is not enough. PCB 20, it is not enough. Soon PCB 24. I think PCB 20 is enough. I think the Western countries, they have conjugated PCB 20 now in the market. If you are giving it, I think you need not give PCB 23. But soon PCB 24 is also coming in the Western countries, then polysaccharide antigen will not be given. Therefore, which other people do receive PCB 23 in our country? Polysaccharide antigens not PCB. PCB means pneumococcal conjugated. I am talking of polysaccharide antigen 23. Senior
More
citizens.
than 2
Senior
years.
citizens, yeah, more than 2 years, immunosuppressed you may give. Suppose a patient is going to undergo splenectomy, you might give it. Okay, patient has undergone bone marrow transplant, you have to revaccinate him from the beginning. Okay, those things we will come to that. This is elementary, doctor, which patients receive polysaccharide bacterial antigen. Now, can you see the next slide? I'll start
Yes,
reading
sir.
and you got
Immune
the slide?
response to vaccines.
Yeah,
Yes,
okay.
sir. Immune response to vaccines. Revaccination with certain bacterial peers, of which group C meningococcus is a prototype, may even induce lower antibody responses than the first immunization, a phenomenon referred to as hyporesponsiveness. Due to this phenomenon, only a single booster of either pneumococcal or meningococcal PS vaccine is recommended, even in patients who require lifelong protection.
It's very important to know when you give adult immunization after the age of 54, now it is PCV 13 is advised. Influenza vaccine every year is advised. I don't know whether PCV 13 booster is required. PCV 23, they advise one dose, no more, no more. If you have a senior citizen, PCV 23, single dose. PCV 13, I think 2 dose. You have to read it carefully. And regarding flu vaccine, you give every year to the senior citizen. Therefore, if you have your father or mother at home, they ask you for immunization. Even now, immunization, even for adults, we are the consultant. Now, meningococcal polysaccharide vaccine no longer, I think we will come into that when we detect it. Therefore, if you want to know what really happens, this is, you can see the diagram. Slide now, changed.
Yes, sir.
So what happens, polysaccharide, it enters the B cells, plasma cells, IgM low level goes into the blood. Doesn't enter the germ cells, doesn't produce memory B cells, doesn't involve high affinity cells, therefore comes straight like this. The germ cells are missing in this. Therefore, what's the difference? We have already, I hope you're seeing the table. You will see that conjugate vaccine, very important difference is because it indicates high antibody, which may act locally also, it reduces the carriage or conjugate. It doesn't decrease the carriage. Community protection, yes, to a certain extent, even in killed vaccines, because colonization is reduced in the nasal mucosa, etc. And here, there is hypo-responsiveness in polysaccharide vaccine. Repeated vaccine, the vaccine will be immune memory, no. Persistence of protection, no. Booster effect, no. Okay. This is a completely B cell dependent and not T cell dependent. Therefore, this difference you should know. And if I tell you the slide here, generation of the B cell does not occur. And the memory B cells does not occur. What does memory? I'll go through it once more. Therefore, in a see, we already told that when you have the cell, the memory B cells go and germinal center and parallel to plasma cells. I think we have seen it. Therefore, we will not go through it again. Now, here, this is given in the purple book, and I like this diagram because it's not given anywhere. This gives you a complete idea. Can you see the diagram? Can you see?
Yes, sir.
Okay. Now remember this. Now this is very, very, very important thing. This is summarizes everything. You give the vaccination, it produces a B cell. The B cell enters the germinal center, high center of IgG antibody is produced, and high affinity IgG antibody germinal center, low affinity outside, and some of them enter the bone marrow and remain there. At the same time, it also produces the memory cells which go back into the and remain ready for act. Therefore, now when you give the primary immunization, actually we are not only giving 2 doses, we are giving 3 doses of immunization, 6, 10, and 14 weeks. Okay. What happens? The affinity maturation and clonal selection of the fittest B cell, here the germinal center, takes 4 to 6 months. Memory B cells take and they are ready. By the booster, we are boosting the memory B cell reactivation by a booster. We have memory B cell reactivation by a booster. It takes at least 6 months for the germinal center, 4 to 6 months, minimum 4 months, better 6 months for the memory B cells to be. If you want to boost the memory B cell, you have to give the booster dose, which is given at minimum interval should be 6 months. Now, we will come to that later also. This is the best immunization is given as 0, 1, and 6 months. We will come to the immunization schedule later. But remember, it is written 1 to 2 doses for induction. Have you ever asked what is the basis of giving 3 doses? We are giving at 6 weeks, 10 weeks, 14 weeks. Remember, they are all primary doses. They are not booster doses because you are giving at 6 weeks, and between that, you are giving it at 14 weeks. There's an interval of only 8 weeks. That is not enough, ideally, to boost the memory B cells, which require at least 4 months. But sometimes we might do that. That's difference. Why are we giving 3 doses, doctor? Have you ever asked? Was the rationale of giving 3 doses? Gopika, are you? Yeah, if you don't know also, you
Yes.
say you don't know, no problem. Then we can proceed. Anyway, I will not go into this, but remember this slide is very important. What does the 1 to 2